Alrighty, we're going to give everybody just another couple of minutes here. It looks like the attendee number is still kind of climbing, so another minute or two and then I'll get started. Also, if you can't hear or see me clearly, please type in the chat box. Megan has been amazing in helping me in my inability to work tech things. So please write in the chat box if you're having some type of technology issue and she can help problem solve for you. All right, well, I will slow roll an intro as it seems like a few more people are jumping in. I do want to introduce myself. My name is Dr. Porcelain. My pronouns are she, her, hers, and today we will be discussing transgender affirming care specifically for intellectually disabled individuals. I did put my personal email on here. It is just my first dot last name at Gmail. And if you want to write that down, please feel free to reach out to me if you have any questions or want to staff specific cases with me after. I definitely want to be a resource to you all because I recognize that this can be some challenging things to navigate. So a little bit about me. I graduated from Wright State Psychiatry residency July of last year, which is crazy to think about that I have graduated now for, just over a year. I currently practice full time actually in Florida. That's where I'm coming from. Yes, the weather is 90 degrees or hotter, and I am active duty military. I am currently at Hurlburt Field, which is in the Destin area, which is along the panhandle of Florida for anybody familiar with the area. So being a psychiatrist in the Air Force is my full-time job. However, my part-time job is telepsychiatry for Access Ohio, and I provide psychiatry treatment for patients with intellectual disabilities all across the state of Ohio. And I do this every other Saturday, and hopefully that gives a little bit of an indication of my passion for this particular patient population. And so ID Psych and then transgender issues are kind of my two major passions. So when I was given the opportunity to do a presentation on those two issues combined, I was really, really grateful that Dr. Gentili gave me this opportunity. In terms of disclosures, I have no financial relevant disclosures. And as I previously mentioned, I am a member of the United States Air Force, and what is presented are the views of my own, and they do not reflect the policies or views of the Department of Defense. The objectives of today's presentation, I really hope that we can start with laying a foundation of terminology and epidemiology of transgender and gender diverse, or TGD, individuals, specifically those who have intellectual disabilities. So we'll lay that foundation, and then we'll really talk about the different approaches that we can take as providers or caregivers in terms of the way we interact with transgender patients. And I will go through the two different approaches, one being the gatekeeper versus the informed consent model. And I hope that will allow us to better understand kind of the art of practicing gender affirming care. Then we'll move into the correlation between the minority stress model and the increased risk of mental health concerns. And the minority stress model is kind of this like academic theory, but I think it really does allow us to understand why trans patients and why patients with intellectual disabilities have an increased risk of mental health concerns. So that will be the why behind all of this. And then finally, I hope to leave you all with a few different practical adaptations of how to interact with them, how we can help our patients explore their gender identity in an affirming way. All right, as promised, let's lay a bit of a foundation so that we're all talking the same talk. I'm going to start in the middle, which is the sex assigned at birth. And as you can see, this little DNA helix is down here. And so the way I like to describe sex assigned at birth is this is what's between the legs. And so the sex assigned at birth is really the traditional designation that a doctor gives. So baby comes out, they look down, and based on if they see external genitalia or not, they say it's a boy or it's a girl. And so that's the sex assigned at birth. That is very different than somebody's gender identity. And so you can see this rainbow up here and that it is in this thought bubble. And so somebody's gender identity is really their like inner sense of self. And so it's the way that they believe that they are. And so somebody's gender identity at times can be incongruent with the sex assigned at birth. And we'll get to that in just a second. Gender identity and gender expression can sometimes get confusing. The difference between these is the gender expression is really the way that somebody dresses or appears. It shows, it's their outward representation of themselves. And so the example I like to give is one of my friends, his gender identity is man, but he often expresses himself in a very feminine way. His gender expression, he likes to wear pink shirts, sometimes floral. He likes to paint his nails. So while his gender identity is man, his gender expression is more feminine. And then we'll move to physical and emotional attraction, and that's really what's in your heart. Who are you attracted to? Who would you want to be in a relationship? Who do you feel more connected to? Laying a little bit more groundwork, I want to talk about the term transgender. And this really is this umbrella term for all of these different words. And we're not going to go into the details of these different words, but I want you to understand that what transgender actually means is it's when their gender identity or what is in their head, what they believe, is not the same as their sex assigned at birth. It doesn't match. Another term that you'll hear me say a lot during this presentation is gender diverse. And I like this because it really points out the progression that we're having in terms of terminology that we're utilizing to describe this patient population. And so you can see that this image was actually developed in 2017. And at that time, we're using the term gender nonconforming. And we have really slid to this other umbrella term of gender diversity, and the reason for that is non-conforming has this negative connotation to it. Non-conforming makes it sound like you're not doing what society wants you to. So in some way that's inherently bad. And so we've removed that terminology of gender non-conforming, and now we're using the term gender diverse. Lots of acronyms. Alphabet soup is very common in the medical field. So I wanted to take just a moment to make sure that these are the most common acronyms that I'll use throughout this presentation. And I want to just make sure we're on the same page. So Transgender and gender diverse is TGD. Gender dysphoria is GD, and I'll get to exactly what gender dysphoria means because it's slightly different than transgender. And then this one we should all be very familiar with, ID is intellectually disabled. Okay, and so let's move on to gender dysphoria. And what gender dysphoria is it's actually the DSM-5 diagnosis. Oh, look, I have my little DSM-5 right here. This is what we utilize. I know we don't have, they're not all medical personnel. Some caregivers are in this presentation as well. This is really what we utilize as mental health providers to diagnose somebody. And so what gender dysphoria is this incongruency between their expressed or experienced gender, so their gender identity, and it's incongruent to their assigned gender or sex assigned at birth. And this incongruency needs to last at least 6 months. Duration is a really important thing diagnostically when we're diagnosing somebody with gender dysphoria. And they need to have at least two of the following. And I'm not going to read through all of these, but I would say that the important thing is this criteria B, which is that the condition is associated with clinically significant distress. So not all patients who are transgender have gender dysphoria, and I think that's one that I kind of scratched my head at early on to really understand that it's the clinical distress that gives somebody the diagnosis of gender dysphoria. So we're spending a whole hour talking about trans issues. How common is this? And so embarrassingly, I actually did a huge deep dive on this question because interesting that there was a hot debate over this in the academic world. They were actually having two very conflicting opinions, and they were writing letters to the editor to each other about how much they disagreed. And the best paper that I found that kind of summarized the debate was this one you can see that was done in 2021, so just last year. And what this study looked at is it was a meta-analysis of 15 different papers, and it showed that the co-occurrence between being trans and having ID, having both of those together, was somewhere between 0.07% of the time and 68% of the time. And so obviously that is a very, very wide range. And this meta-analysis really broke down why. Why does the research show such inconsistent results? And one of the conclusions they came to was my last point on here, which is that there was really a large variation in the way that the studies were conducted. So when studies aren't conducted the same, they use, everything that they do in the study is different, we get different results. So that's to be expected, even when the study is asking the same question. And so one of the studies talked about, and this was the one that showed 0.07, so really low co-occurrence rate. This study hypothesized that maybe part of the reason they had such low results is that the feelings of gender-based distress can often be missed. So we know that in our patient population, we have such a wide variety of verbal abilities and ways to express themselves that gender identity is a fairly complex topic. And so maybe we were just missing some patients that were experiencing gender distress because of their ability to communicate that with us. One of the other studies, the studies that were showing this really high co-occurrence rate, hypothesized that maybe the reason it was so high was they were using very outdated reference groups. And so reference groups being neurotypical patients and cisgender. Sorry, I didn't define this earlier for you. So transgender is when there's that incongruency between the sex assigned at birth and your gender identity. Cisgender is when it is congruent. What the sex was you were assigned at birth and your gender identity is the same. So cisgender reference group was a decade old, and so they might have underrepresented the prevalence of transgender people at that time. Because if you think back over the past decade, there really has been this huge swing of acceptance and communication and talk and interest in transgender and gender diverse individuals in general. And so they were thinking that maybe some of the methodology wasn't great in the studies that they've done so far because the reference group that they used was fairly old. So sorry I had to nerd out a little bit. I spent so much time diving into this deep dark hole that I wanted to at least do one slide on it. And I think the take home message of all of this is that we need more research. We need more people to be talking about trans issues in the ID population because it's obvious that the current research just isn't enough. One of the biggest questions that I get is how does transgender and gender diversity present in the ID population? And one of the biggest things that I noticed is that it is more of a behavioral presentation as opposed to declarations. And what I mean by that is in my neurotypical patients that I see Monday through Friday in the Air Force setting, those patients will walk into my office and say, "Hey, I'm transgender. What do I need to do to get started on hormones?" That's a declaration, right? They're very sure that this is what's going on. In the ID population, we see more behavioral presentations. And so that can be stuff starting to pop up through their gender expression. So it could be them, maybe being interested in painting their nails when somebody next to them is doing that, or being interested in, if their sex assigned at birth is male, maybe then they're interested in wearing dresses. And so let's really be tuned into the behavioral gender expression to lead us to better understand somebody's gender identity. Also, in the ID population, we see trans and gender diverse presentations at an older age. And so, the gender concept is complicated. And for a neurotypical patient, normally gender identity starts to establish around the age 3 to 5. However, in intellectually disabled populations, because they are developmentally delayed, that onset of gender identity often happens later. Additionally, sometimes the patients just are confused about their gender identity. And I gave the example of what I see in the military population that they have this very clear trans identity. And I think it's important that in our patient population with the ID patients that they might present as confused, and that's okay. It doesn't mean that their gender identity is less substantiated. It just means it's sometimes a little bit harder for them to navigate the intricacies of gender identity. So what is the process of gender transition? So somebody is transgender and they're interested in transitioning. My answer is always it depends. It's really based on what the patient needs to feel affirmed in their body. And so for some people, it's really their gender expression needs to change. So they want to, appear externally differently to the world. Some people are interested in um, changing their name or their pronouns. Other people are really interested in coming out and talking about their gender identity to their family, their friends, their caregivers. In some people's gender transition will involve hormones or surgery. And surgery, there's a very wide variety of surgery, and I really think that's out of the context of this presentation. But I hope that you take away from this slide specifically that gender transition is specific. What one person needs, another person might need something else. And so it's important that we empower our patients to communicate what their needs are to feel affirmed in their body. So how do we approach patients who are transgender and gender diverse? I like to think about the approaches on this continuum, and I'll kind of walk through what each of the different models mean and explain how we can navigate the models. So all the way to the left, you can see the gatekeeper model. And what I mean by gatekeeper is that we as providers or caregivers have the shiny golden key and the gate is behind us. But in order for the patient to pass through to the other side of the gate, they need to like prove to us that they are trans, and that once they prove it, then we'll unlock that gate and allow them through. This is a very paternalistic approach, and in comparison, the more autonomous patient autonomy approach would be the informed consent model over on the right. And the informed consent model is us giving patients information about gender identity, gender expression, about the process of transitioning. And with that information, they being, based on their lived experience, best able to make the decision of what being transgender would look like for them, what their transition process would be. So I'll talk a little bit about the pros and cons of each. In terms of the gatekeeper model, I think when we are entering a patient interaction, our client interaction, as a gatekeeper, I think our intentions are inherently good. We're trying to be really thorough. We want to ask all the questions to really make sure that the patient's making the right decision. In our opinion, I do think our intentions are good. However, I think it's extraordinarily important that we see this gatekeeper model approach from the patient side. And what that is they will see us as a barrier, and they'll start to distrust us because they really see us as a negative thing rather than an ally that's there to support them. In terms of the informed consent model, this is very collaborative. Patients feel better about this, that we're working with them, alongside of them. We're in lockstep with them during this process. And I think the worry about the informed consent model is that somebody will be misdiagnosed. And that's not necessarily misdiagnosed as transgender, but really misdiagnosed that we're going to miss a co-occurring condition. And we'll get to all of the co-occurring conditions, the increased risk of mental health diagnoses in these patients. All of that to say, it's not black and white, right? It is this continuum, and it's important that you look at these different approaches and find your style and see where you land along this. I would encourage you to lean more towards the informed consent model, because the gatekeeper model can really contribute to stigma, and stigma, unfortunately, is something that trans patients experience all the time. And in order to conceptualize stigma, I want to talk about the minority stress model. And I do kind of nerd out about this as well. I'm hoping that it lays the foundation for us to understand why these patients have increased mental health issues. So I'll walk through it with you. The first side over to the left is demographics. And so what places somebody in a minority status? So that can be gender, right? So trans people are a minority. That can also be developmental stage. So our intellectually disabled patients, both of those automatically put them in a minority status. All human beings on this planet experience stress. However, patients who are a part of a minority group have increased stress. They have increased risk of rejection, discrimination, as well as stigma. And because of these increased stressors that they're experiencing, they have increased risk of mental health disorders, everything depression, anxiety, suicide, substance use. So let's zoom out here and look at this beautiful island, and let's hypothetically think that all of us in this lecture today are born and raised on this island. And on this island, 90% of the population is transgender and has an intellectual disability. So if 90% have those two things, they now have the majority status, right? They're no longer part of a minority group. And so on this island, they would have improved mental health outcomes because they would experience less discrimination, less rejection, less stigma. So let's break down a little bit of the stressors, and I want to talk about discrimination. This data that I have and the next couple of studies that I will show are for the general population. So this research does include neurotypical patients. As I mentioned, there's just not enough robust research for this type of data specifically in the ID. So I'm going to paint the picture for neurotypical patients as well. So patients in the minority stress model experience lots of different types of discrimination, if that's healthcare, employment, housing. And I'm sure as I'm reading those three things, many of us are thinking, well, yeah, of course our ID population experiences all of those. And so if this study is showing that for trans patients, 40% of them experience discrimination, we can only guess that trans patients who are also intellectually disabled would have an even higher risk of discrimination. So let's talk about mental health outcomes. As a psychiatrist, obviously, this is a very important point for me. So as I said, this is for a general population, just not ID. And this study does come from a really big transgender study in the United States with over 27,000 people. And so we'll orient ourselves really quickly. On this x-axis, you can see different age groups. So age 18 to 25, age 26 through 29. On the y-axis, you can see a percentage of people who experience serious psychological distress. And the difference between the two bars are the dark or filled in bars are for trans patients, and the clear bars are for cisgendered, so trans versus cisgender. And I think this graph is really, really telling that there's a huge increased risk of psychological distress in trans patients. So we'll break it down. Here's another study done in Massachusetts, and this looks at the number of depressed versus the number of depressed and number of anxious days that patients who are trans experience. So transgender status, people who say yes to that, 7.79 depressed days. And so that's in comparison to their cisgendered counterparts, which experience just over 4 depressed days. And you can see that increased risk of anxious days as well for trans patients over cisgender patients. Suicidal ideation. This one was pretty striking to me, and I kind of want to foot stomp it a little bit. As you can see from this data, this is the number of trans patients who have suicidal ideation. And so 30% of trans patients have suicidal ideation. And that's in comparison to cisgender people is about 3%. So it puts patients at a 10-fold increase of suicidal ideation simply being trans. And as I said, this is for neurotypical patients as well. We would have to worry about our patients who are both transgender and intellectually disabled, that they would have an even higher risk. All right, so I hope that the minority stress model gives us the answer to why. Why do trans patients who are intellectually disabled have increased risk of mental health? And I don't think I ever grew out of my 5-year-old phase of why, right? People who have 5-year-olds know that is a very common question in that age group. And so this is the why. It really is because of the minority status that they have increased stressors, which worsens their mental health outcomes. Okay, so a lot of this has been doom or gloom. So I hope to spin it around and say, what can we do, right? I want to empower us as providers to have strong therapeutic interventions. And so the first one is just being familiar with gender diversity. And I hope after this presentation, you'll feel just a little bit more comfortable with the concepts of transgender and gender diversity. The next point is encouraging people just to change the way they talk slightly. And so I would encourage you to use gender neutral and non-heteronormative language. And what do I mean by that? So I'll give you a few examples. So we can say things like, do you have a partner? Using the term partner is gender neutral in comparison to saying something like, do you have a boyfriend or girlfriend? Also, just a small thing, if you're inviting a group of people towards you, you can say, everybody come over here rather than ladies and gentlemen, because that is so gender specific. Additionally, we really just want to use open-ended questions about people's sexuality. So rather than somebody asking me, do you have a boyfriend or do you have a husband? The way you could ask that is, what is your sexuality? Or do you have a partner? As we previously mentioned, those open-ended questions allow patients to feel more comfortable disclosing how they're truly feeling. If you pigeonhole them into, do you have a husband? Then I'm like, oh no, what do I say? Do I just say like yes or no? So open-ended questions while navigating somebody's gender identity and being curious about, what that person's lived experience is extraordinarily helpful. The next point is sexuality education, and I would say sex ed is something that people are kind of uncomfortable with talking about and asking about. One of my mentors in training always said, don't forget to ask your patients about sex, drugs, and rock and roll. And honestly, I still use that verbiage today. I find that patients kind of laugh at me and it disarms them a little bit, so that I'm able to ask these questions about sexuality and substance use, which can be two really challenging topics for patients to discuss. And it also provides me the opportunity to give that educational piece. The final point on this slide is identifying social support networks. And so when you are part of a minority status, it's really helpful to be around others who have shared lived experiences. And so finding LGBTQ plus gatherings for our patients to be a part of can help normalize what they're experiencing. A few really simple, like no-brainer things that we can do in our spaces, whether that be, in a clinic, in a group home setting, in a day hab, is just have inclusive signage. And so changing something to an all-gender restroom can be really helpful, or putting any of the LGBTQ plus welcome signs around a space can help people see something and say, oh, okay, I am welcome. Pronouns is another hot topic. And as you can see at the start of my presentation, I said what my pronouns are. I think we really just need to normalize that. And rather than asking what are your preferred pronouns, the really small thing that we can change in our verbiage is just saying, what are your pronouns? When we use the term preferred, it would be like somebody asking me, what is your preferred last name? Is it porcelain? Well, that's just my last name. Like, what is your last name? Oh, my last name is porcelain. And so hopefully that example allows you to understand that somebody isn't choosing their pronouns. Their pronouns are really what their gender identity is. Another therapeutic intervention that I want to talk about is if you have a patient that is starting to express, through potentially some behavioral presentations or gender expression, that they need a space to help explore their gender, there are a few things that we can do. The first one is just encouraging lived experiences. And if that is allowing our patients to pick out their own clothes, you know, the wearing makeup and painting nails are the next two I have on the slide. And I think, a way that we could reword things is if somebody is interested in painting their nails, rather than saying if that member is their sex assigned at birth is male, rather than saying, no, painting your nails is for girls, just allowing them to have that exploration. I think we really need to break down some of the societal gender norms to allow people to feel more comfortable with exploring their gender identity. There are tons and tons of books and exercises online. I put a couple of my favorites down here. The one is the Gender Identity Workbook for Teens. And it does say teens, and so I would ask you to think about, okay, what's the developmental stage of my patient or client? And if a teenage exercise is appropriate, then this could be a really good one. I did an excerpt here from one of the activities that I really like in this book, and it's called Fantasy Island. And what this is saying is it's encouraging patients, it's giving them the space to say, if you lived in a perfect world, how would you look? How would you dress? How would you present yourself to the world? I think this fantasy island gives patients the ability to articulate some of those questions about gender identity. And it's really important when doing these types of exercises that we're thinking about the patient's ability to communicate with us. So, for some patients, it might be that they can verbally explain to you what that might look like. For other people, based on their verbal skills, you might want to pull out a magazine and have them point at things saying, this is how I wish I could dress. This is how I wish I could present myself. Because verbal language obviously can be a struggle for some of our patients. And in general, I think we just need to allow for more autonomy. We all know that the patients with intellectual disabilities live in highly, highly, highly structured environments, whether that be in their group home or at their day hab. And I think this structure provides a lot of help for many of our patients. You think of your patients with autism and you say, well, of course they need that structure. But I ask you that if appropriate and if the patient can tolerate, giving them that autonomy can help with their exploration for their gender identity. Okay, this is a big one. This is one I always get questions on, and this is the question of capacity. And so just to define capacity, capacity is the ability to make your own decision. And I would like to frame gender identity as a very private and subjective experience and not necessarily a decision, right? A trans person doesn't decide to be trans. That is just what they are. So I would encourage us not to challenge somebody's gender identity. I think there's a big difference between challenging and being curious and asking open-ended, inclusive questions. But with capacity in mind, many people are saying, all right, Dr. Porcelain, well, yeah, that's all nice. But what happens if we have a trans patient and there needs to be an actual decision about their social transition or informed consent to make a medical decision? And these decisions obviously fall on the guardians, the families. And I just encourage you that if you're in a place or in an environment that decision needs to be made for the patient, that we're doing what's in their best interest and that we're really leaning towards the informed consent model whenever possible and, not being gatekeepers. I like to reframe this to say, would you ever ask a cisgendered person to justify their identity? That wouldn't be something we would ask, but since trans patients are a part of the minority, they get asked these extra discriminatory questions. And so, this takes us right back to the minority stress model and that asking transgender and gender diverse persons to justify, and I want to, really footstep this. Justifying it is different than being curious and asking questions. But asking them to justify to prove to you that they're transgender is really just contributing to that minority stress model. And because this is an extraordinarily complicated thing to navigate, and I, am almost about to finish up to really allow time for some discussion and questioning that as we're trying to navigate this, here are a list of really good community resources in Ohio that can help you and people going through a transition, help you and your patients going through transitions navigate the situation. All right, bottom line here is just be a good human on this planet. Be open, be welcoming. These seem like such simple things, but I really think that they are imperative to us providing gender affirming care. The very, very last point I want to say is don't be fearful of saying something wrong. And I know throughout this whole presentation, I was like, well, don't say this and say this instead. I was really just trying to help you develop a different way of communicating because we are going to mess up. We are going to say things wrong, and that's okay. To self-disclose a little bit, I misgendered a patient last week. And in that situation, I apologize and you move on. I think it's really important that when we mess up, we don't perseverate on that error. We apologize, we're humble, and yep, we're human beings, we're absolutely going to make mistakes, and then you just move forward with the conversation. All right, with that, I will open it up to questions.
All right, Dr. Porcelain, we do have one question in the queue right now. Um, I am fine with gender diversity and choices. However, I question if a male who identifies as a female competing with females may not be a fair sports challenge, and your thoughts around that.
Oh boy, I think that's a whole nother topic. That could be a presentation in itself. Um, and I would say in general, it's important that we aren't contributing to the stigma, to the discrimination of trans people, right? Let's conceptualize that question in the context of the minority stress model, and that is it fair? Is somebody who's sex assigned at birth male, would they maybe be bigger and stronger than a cisgendered woman? Yeah, maybe. But I think it's more important culturally that we accept that person and their differences and allow them to participate, and don't stigmatize their gender identity. So I have, way more to say about that, but I'll leave it at that. I think there's really, really good debates. I would encourage people, there are tons of really, really smart people, way smarter than I, um, who talk about these issues on YouTube, on the internet in general. So just education is key. So go out there and try to hear different sides, and hopefully that will allow you to better understand what it would be like for a transgender person attempting to play sports.
Okay, and we also have a request to go back to the resources slide, if you could.
Yeah. And we also have these slides attached. They're in the handouts. I don't know, Megan, can everybody else see what I see in terms of the two different handouts?
Yeah, so it looks like we've got the slides in there, but there's also a Word document that's got some information in there for you.
Yep, so the slides are all there. So you will be able to take that with you. So all of the resources are on there. And then the Word document, I tried to make a one page that turned into two page because I liked some of the figures so much that I had to do a second page. So it really is a two-page handout with some of the high yield information that we talked about.
All right, we've got some other questions starting to filter in. We
Okay.
have had several individuals apply for DD services that have autism and also identify as a trans person. In your opinion, do individuals with autism seem to identify as more gender diverse than others?
Great question. And I'll go back to, one of my slides, my deep dive into the actual research. What am I technology? Am I capable? It's hard. But as I'm going back to the slide, there was originally, the early research was showing that they thought there was an increased link between gender diversity and autism and intellectual disabilities as a whole. Then I try to outsmart the computer here. But the current research, the jury's still out. And so we can see here, let's see as well. Megan, you can correct me if I'm messing something up. I thought I
There we
that
go.
so this is the co-occurrence rate between intellectual disabilities and transgender and gender diverse. So they really did think some of them were showing 68%. In terms of neurotypical patients, they were thinking that for neurotypical patients, about it's just under 1%, somewhere between 0.6 and 0.8, somewhere in there is the percentage of neurotypical patients who identify as transgender. And so when some of these studies started to come out showing a co-occurrence rate of 68%, people were like flabbergasted. But the more research that comes out, we're seeing just this huge range of co-occurrence. And so I don't have a good answer for you yet, but I'm hoping that this meta-analysis that I talked about, the one that came out in 2021, will encourage further research to really look for if there's a link or not.
All right, next question is, do you recommend adding your pronouns to things like your email signatures and Zoom names?
Yay! Yes, I absolutely do. It was a really big win. So I mentioned at the beginning, I am active duty military, and military has a lot of rules. And the military this past year actually passed that we're even allowed to put our pronouns in our official signature blocks. So absolutely, it is in all of my signature blocks. I always try to put it at the beginning of my presentations. If you can have it on your badges, I think any way that we can normalize saying what our pronouns are, the better.
Fantastic. All right, next one is, along with working with your patients, do you provide resources for parents of younger individuals?
So me personally, I can be, a non-clinical research if somebody has a question and, needs help navigating it. Absolutely. This is where my passion is. And so I want to be able to be there, but I don't um, work in a clinical capacity providing resources to younger individuals or families.
All right. How can we best support a person who made a transition but then regrets having made that transition for whatever reason?
Yeah, that's a really good question, and is often a hot topic, especially when talking about younger people transitioning of, oh, are they too young to really have solidified what their gender identity is? And I would say the same way that we want to conceptualize the informed consent model for helping a patient identify what their gender identity is and transition, I would take that same approach in if somebody's gender identity is they're more confused and now there's some regret or there's something going on there, is to just continue to provide them with information and allow them to be the ones that make the decision. As I've said previously, the patients themselves are really best equipped to be making these decisions. So let's empower them, let's give them information so that they can make the decision.
All right. Can you provide some methods of dealing with people who just flat refuse to use people's pronouns and approach the issue with a lot of anger and dismissiveness?
Yeah, I think anger is a really, really common reaction, especially in people who are experiencing repeated discrimination. Anger comes to the surface. We know that, historically, that is absolutely something that we see. I would encourage patients or people who are experiencing anger about a topic just to take that 1 second and take a deep breath and see if you can provide education. Education is so, so important. And I would say that framing those conversations with I feel statements like I'm feeling a lot of anger or frustration when you say this because, and then giving your explanation. Somebody cannot take away your feelings. Your feelings are your feelings. And so, um, on top of like factual education, expressing how you feel when somebody says that, I think can be really enlightening for somebody else. And it's very important that you're able to take that deep breath and express those feelings in a way that is palatable to the person receiving them. Because when we come at people with tons of anger, the automatic thing is defense, right? Defense, I'm going to put you at arm's length, stay away. If you're able to take a moment and give an I feel statement, that really does open a door potentially for a person to listen to what you have to say.
I regularly provide training on sexuality issues and IDD. Gender diversity, including the gender unicorn slide, is discussed, but this topic can
Yay!
cause obvious discomfort among families and some professionals. Any
Sure.
suggestions on talking with families about this topic?
I would just normalize their feelings. It is uncomfortable. Anything that isn't normal, people don't necessarily understand. And so, rather than taking the approach of like, you shouldn't feel uncomfortable by this. This is the way the society is going. Like, hey, it's really normal to feel uncomfortable, and we welcome that discomfort and ask those questions. And don't be afraid to say something wrong in this setting. Please, like just say what your thoughts are and let's navigate it together.
In a neurotypical individual, you said typically you would see transgender tendencies earlier in life. Do neurotypical individuals find out that they are trans later in life? To diagnose a person with gender dysphoria, are there specific answers looked for? If they look up things to discuss this and try to manipulate the team, are there ways to identify this?
Okay, there were so many questions there, and my little brain could only handle some of them. Can you give me the first one again?
Sure. In a neurotypical individual, you said typically you'd see a transgender tendency earlier in life. Do neurotypical individuals find out they are trans later in life? I think
Or
maybe
typical,
we're
I think.
missing an atypical, yeah.
Atypical. Yep. Okay, so the question is, yes, in general, neurotypical patients start to identify their gender identity around age 3 to 5. And yes, we often see that because of the developmental delays in the intellectually disabled, that their gender identity does come at a later age. And it really does base on what their developmental delays are. Okay,
All right. Second part is to diagnose a person with gender dysphoria, are there specific answers looked for? And then the kind of the follow-up to that is if there are these specific things, are they if they are looked up to discuss to try and manipulate the team, are there ways to identify this?
okay. I was just gonna try to pull up the gender dysphoria slide. I would say, as a psychiatrist, I would be the one making the diagnosis, and just as patients could maybe look up ways to say what the different criteria are for major depressive disorder. Um, those who are familiar, the SIGI cap, so sleep, interest, guilt, energy, concentration, appetite, psychomotor retardation, depression, and suicide. Those, yes, somebody could look it up and say, I am this, I am that. However, I do think that the art of psychiatry really comes into play here. And through a clinical conversation, we are really able to tell if it is like a genuine part of the person's narrative versus if it is like scripted or textbook. So those nuances, I think, are absolutely something that we're trained on as psychiatrists to better understand. So if you don't feel like you necessarily have that training, my recommendation would be to get them to a psychiatrist to really do that evaluation.
All right. How do we support someone who bottles up their gender expression because a parent doesn't approve of it?
Yeah, that's really, really hard. Get back to education, education, give them information, allow the patient the space if they feel like they don't have the space with their parent. If your role is as a caregiver or, as a social worker, a case manager, whatever that may be, I would just encourage you to provide that space for them. And as they become more comfortable and confident, that could be something that then they would feel comfortable talking to their parent. I think this question brings up a really, really important point, which is that we never want to out our patients. The patients discussing their gender identity with families or caregivers is on their own timeline. It's so important that we don't rush that or pressure that. So just give them that space, be inclusive, be open, be curious with them. And when it feels right to them, if and ever, they will talk about it, but we want it to be on their time.
I recently left a county board in Ohio, and this county board actually changed their policy so no one could put their pronouns in their name in the email signature after one employee did. How do you suggest these kinds of things be addressed when an agency is changing their policies to not accept it?
Yeah, that just breaks my heart. I know it's out there. I really do see that as a step backward. We're the way I would approach that is that I would, provide them with education and evidence to why it's so important that we provide an inclusive environment. And hopefully with education, they can see that by them removing that or restricting our ability to put pronouns in, we really are increasing the stigma in the minority stress model. Sorry, I love the minority stress model. And we really are contributing to the problem. And as, you know, helping people, that's why all of us are here today. Inherently, we want to help others. If we are able to articulate how this might be harmful, hopefully they would understand.
Do you have any suggestions on assessment with children with TGD who have parents who are non-supportive of their gender identity? I have previously had parents remove adolescents from my care due to asking about and affirming gender identity in their intake session?
Yeah, it's such a tricky one. How do you navigate it? I really think that's the art of practice. As you have an experience where somebody removed the care, can you open the conversation with the parents and hear their side? And I think, as providers, we have to be humble. We have to learn from these experiences. We have to see what it feels like from the parent's perspective. And so I would just encourage conversation. And learn from those experiences. I think humility is everything in what we do with these really, really sensitive topics.
Just a quick comment in here. I wanted to add that somebody else who is working for a county board of developmental disabilities in Ohio, and they are encouraged to put pronouns in their email. So clearly we've got some
Yay!
diversity amongst the group here.
I love it. Good.
How can you reconcile what to say or how to act if they project conflicting information? For instance, if a self-identified transgender teenager says they want to have gender reassignment surgery but wears skirts, does makeup, and projects their assigned gender at birth, how would you explain that to a child?
Okay. Man, it's so hard. It's really testing my like verbal comprehension here. So I think the question is essentially, what do we do if there seems to be some incongruency between their expressed gender and their sex assigned at birth? And I would just encourage the conversation of that gender isn't necessarily binary. And I think in one of these, it talks about here, so under transgender, non-binary really is an option. So, I think we need to take gender out of the boxes of this is what is male and this is what is female, and understand that there is non-binary and there's gender fluidity as well, that, they might feel this way in one setting and this way in another setting. And the best thing that we can do is just affirm their experience that gender affirming care is everything rather than shoving them into a box, say, hey, whatever you're feeling, however you want to express yourself, that is okay. And I will accept you for who you are.
We did have a couple of questions about recording. This session is being recorded, and you should have a link to it emailed to you in about a day or so to the archive. I texted the answer. I didn't know if everybody saw that. Next question. You stated, don't pressure or out our patients. I have a 70-year-old female cousin that has expressed transgender behavior her entire life I've known her. How can I tell her I support her if she ever wanted to express her truth if she is in fact trans? I feel she's been an unhappy person because she has never been her real self.
Yeah, I think that's a tricky one. In similar situations to this, I have just talked about my opinions and thoughts on trans issues and gender diversity in front of the person. So, not necessarily calling them out, but making sure that they know what I believe. And so, with my opinions in the room, that might provide the foundation for them to feel comfortable talking. So, just share that what your feelings on the issues are. Can be tricky to navigate that into conversation in a discreet way, but that would be my recommendation.
All right. We have just a couple of moments left, so if anybody's got questions, please try to get them in the chat here.
I did just change the slide back to the intro. What we attached, I forgot to have my email on the PowerPoint slides that are attached. So if you do have any questions, concerns, or want to staff anything with me, take a moment to write down my email. It is just first name dot last name.
Wonderful. I think we've just got some comments thanking you for your time, and it was a great presentation.
Awesome.
But it
Thank
looks
you,
like we're
everybody, for joining. I know this is a difficult topic and some people feel discomfort with it. So I'm just grateful that we had such a good showing and that I really appreciated your all's questions. I thought they were extraordinarily insightful and really, really good ones.
All right, looks like we are all wrapped up with questions for now.